Thanks for having me. My name is Papavarnavas. I'm an infectious disease specialist. I've been working here for a while now, so I see some faces that I remember and a lot of new faces. So thank you for having me. Thanks for Gift and Tashini for organizing. I think this is quite an important topic because you guys are the first ones to see these type of patients. So nothing special about the title other than the fact that it is diphtheria, and it's based on the problem of that we've seen a few more cases popping up in and around the Western Cape. So I thought this would be quite a nice talk to give you guys. Okay, so let's talk about what's happened recently. So in Nigeria, there was quite a large outbreak in 2022, 2023, in which on the 5th of October last year, they reported 13,000 odd suspected cases with about 500 deaths of diphtheria. I mean, it's a massive outbreak. And then last year, I'm sure you guys will remember, or at least read it in the news, about the Portsmouth prison outbreak of diphtheria that occurred, which was quite interesting. So let's go into a bit about what is the case definition. So it's a patient that presents with an upper respiratory tract illness, who then also has a sore throat, a low-grade fever, and importantly, a pseudo membrane or an adherent membrane, whether it's on the pharynx, the larynx, the nasopharynx, etc., or the tonsils. And as you can see over here, this is what the pseudo membranes look like, and you can see it's a whitish grayish membrane sitting on the uvula and the tonsillar regions over here. And then this is a patient that's got bull's neck, and that is the cervical adenopathy, which has just become so enlarged that now can cause stridor and etc. You guys know more about that than I do. Okay, so what are the clinical manifestations of diphtheria? And as you can see over here, one of them is cutaneous, and this has been seen in patients that are IV drug users, homeless, etc. And then cardiotoxicity is a big issue over here. And I'm sure you guys can see that this is not a normal looking ECG, and in actual fact, this is a complete heart block. And what's really interesting about this complete heart block is that there was a very old study of small numbers, probably in the late 80s, early 90s, where they recorded patients that presented with cardiotoxicity, and the mortality from a complete heart block was sitting at 100%. So a very severe form of diphtheria. And then, as I'm sure you know, there's other issues with renal failure. And then another interesting part is the neurological signs, which actually happen a few weeks to a few months after the development of diphtheria. And you're more likely to develop the neurological stuff if you've had pseudomembranes with a bull's neck. Okay. Right. This is an important slide from an IPC and an infection prevention and control point of view, and that is related to the incubation period of the disease. And as you can see over here, that the majority of patients will start to present with symptoms within the first 1 to 2 days, and actually it sits at 1.4 days over here. So from an IPC point of view, this is very important that we pick up those people that have been exposed to patients with diphtheria because of the risk of them developing disease, etc. But generally, the incubation period goes up to about 10 days, and the chances of developing diphtheria after that is minimal. Okay, so what is seen as an exposure to a suspected case? So this is the case definition, and I put this at the top, is the resuscitation, which you guys are commonly involved with. You're manipulating the airways, you're in theatre, you're resuscitating patients, and in that case, you need to wear goggles, you need to wear surgical N95. Surgical mask is not sufficient, all right? And then obviously you're wearing your theatre attire or an apron, that is fine. And then the difference comes in for people that are not in the theatre. So for myself, when we see these patients, you need to at least wear a surgical mask, an apron, and the gloves. Okay? And important in this definition is if you have not worn a surgical mask and you were within 2 meters and for more than 15 minutes, you are seen as a contact. So if you are nursing sister, you go and do a blood pressure on this patient, you're there for what, a minute, maybe? Okay, you're in within 2 meters, but you're there for a minute and then you leave. You're not seen as a contact, okay, because you had to have been there for more than 15 minutes. And in the outbreaks that we've seen, I've actually said to people, even just by wearing a surgical mask and doing hand hygiene was sufficient. But obviously, if you are seeing the patient, they should ideally be in their own room, putting on the proper PPE, etc. Okay, and then family, friends are also seen as contacts. Those are patients that have been exposed to them in the last 5 days, same household, sexual exposure, etc. All right. Now, this is an important slide in the sense of if you are exposed, what do you need to do? Okay, so there's 3 things that have to happen. You have to do all 3, not 1 or 2 or 2 or 3, it's all 3. So firstly, you need to, as a healthcare worker, you need to be swabbed, all right? You then need to get your azithromycin and you need to get your vaccination. If you've been vaccinated in the last 10 years, then you don't need that component. Then you can get 2 of 3, all right? And what I mean by vaccination, we'll get into it a bit later, but it's basically tetanus, diphtheria, Tdap, etc., etc. Okay. Now, as I've already alluded to, when you're seeing these patients, it's very important that you have the correct contact precautions. So you'll wear your surgical mask, your apron, your hand hygiene, and then for you guys, especially in theatre or in the wards over here when you're suctioning, please wear an N95 with goggles. All right. Now, you as a healthcare worker come to me and you have the definition of a contact. What do we do for you? All right. So we are going to swab you. If your swab comes back as culture positive, toxin positive, you need azithromycin for 14 days, plus minus giving antitoxin. And then we're going to ask you to isolate for the next 10 days or no, actually, longer. You'll isolate until we do 2 swabs on you 24 hours apart, and that's at the end of treatment. And that's because obviously we don't want you to spread the disease to other people. Okay. If you as a healthcare worker are culture positive but toxin negative, then you get azithromycin for 7 days. So please note the difference. This is why it's so important that we swab you, and it's because the duration of therapy as a contact will change. Right, and then you're going to wear your mask and you're going to check for symptoms, and you'll you'll check for symptoms because you're asymptomatic, right? If you develop symptoms, then you're going to have to stay longer in precautions, and then we're going to swab you at the end of the 2 weeks of treatment. Now, if you are culture negative, toxin negative, you still need azithromycin, all right? And that is because I might have swabbed you early on in the disease process and you haven't developed symptoms yet. So I need to make sure that you don't develop symptoms. So we give the azithromycin as a post-exposure prophylaxis now, all right? And again, 10 days, and then if you develop symptoms, we swab you and we check if you've developed the disease. Okay, chemoprophylaxis, what do we give? So penicillin is sufficient, and then azithromycin is the other option. And that's the NICD guidelines, all right? In the cases that we've been exposed to, we've actually gone down to the azithromycin rather, and that is based on some of this data that we've been seeing, and some of the cases that we've seen have also been have had penicillin resistance. So this is from that big Nigerian outbreak, and as you can see, erythromycin, so also macrolide, had more than 90% coverage of the diphtheria, but we use azithromycin. I'm sure many of you don't want to use erythromycin because of the side effect profile of it, running to the toilet, etc. But as you can see, benzyl penicillin, more than 90% are resistant. So it's not the antibiotic of choice for prophylaxis. Okay. Told you about the chemoprophylaxis. Now we're going to move on to the vaccination side of things. So what are the vaccines that you need to get? You need to get TD, tetanus, diphtheria. I prefer Tdap, all right, especially for you guys who also work with the pediatric population, where you're going to see patients that present with pertussis, etc. So it's good to have that extra little bit. The other option is Tdap with polio, with Haemophilus influenza, hepatitis B, or the other option is Tdap with polio vaccine. And why do we vaccinate, right? So vaccination is very effective against toxin production. Okay, so Corynebacterium diphtheria can produce toxins, not in every single case, but it depends if it's the toxigenic or the non-toxigenic strain. But if you're vaccinated, you're essentially protected against the toxin. It also protects you against symptomatic disease. And if you are vaccinated, you're less likely to transmit. And in the outbreak that happened in Nigeria, the best way to curb the outbreak is by doing mass vaccination, because if you mass vaccinate people, you get herd immunity and you decrease the risk of transmission by 28%. Okay. I'm sure many of you are aware of this EPI schedule. And as you can see, that for the pediatric population, they are vaccinated at many different time points, 6 weeks, 10 weeks, 14 weeks, etc., etc. Okay. And of note, the last one is at 12 years. And why this is important is that, unfortunately, we don't have adult vaccination guidelines. So I'm sure if I asked some of you in this room here, when was the last time you got Tdap or TD? Many of you might not remember, okay, unless you maybe cut yourself on a rusty nail or on a gate or whatever it is, then you might have got your tetanus shot with your diphtheria. And this is the problem, that we don't have these guidelines to tell us, hey guys, every 10 years you need to get your Tdap. So what I'm saying to you is, as healthcare workers, I really, really advocate for getting vaccinated against this disease. Okay, and this is one of my favorite slides because it just talks to so much about why vaccination is so important. So if you're unvaccinated, you have a 70% chance of developing prodromal symptoms, and then 80% of those patients will then develop membranous diphtheria, and then 5 to 50% will develop, will die, okay, and 50 to 95% will recover. If you're unvaccinated, 30% will go into asymptomatic carriage, no transmission, recovery. But look, if you look over here, vaccinated, 90% become asymptomatic, and the vast majority will recover. Whereas over here, if you see, the 10% will develop prodromal symptoms, but the vast majority will recover, and very, very few patients will develop severe disease in the form of membranous diphtheria. So once again, showing you why it's so important that we vaccinate our patients as well as ourselves. Okay, this is a figure which illustrates what vaccination looks like around the world. And as you can see, in many of the first world countries, vaccination is sitting at more than 90%. But if you look at South Africa, we were sitting between 80 and 89%. But please note, this is in 2019. And as we all know, when COVID hit us, we then had less vaccination being rolled out. Yeah, you had a question.
I just wanted to ask, what's the kind of case definition of vaccinated? Is it having got all your childhood vaccines for Tdap or diphtheria, or is it an adult who's had their booster or vaccination in the last 10 years?
Yeah, so we'll go in the next couple of slides with waning immunity. But ideally, if you're partially vaccinated, not good enough. If you're fully vaccinated, then I'm so I know you're going to say, but how are we going to know if a patient's been fully vaccinated? It's a difficult one. We're hoping that their road to health card was fully ticked, etc. But yeah, we'll get into that now. That's a good question. Okay, so what I wanted to show you is Nigeria, as you can see over here, that only had 50 to 79% Tdap coverage, which talks to the fact that they had that massive outbreak. You need about 85% coverage for herd immunity to occur. Okay, this is what you were alluding to. So if you're partially vaccinated, as you can see, if you have at least 2 doses, it's 71% effectivity against severe disease, etc. If you're fully vaccinated, you have 87% effectiveness against symptomatic disease. And this is quite interesting because what you can see over here is the age groups. And if you 0 to 4, you have 96% vaccine effectiveness against symptomatic disease. Whereas if you're partially vaccinated, you have 91%. And what happens is, as you can see, as time goes along, your immune system, your immunity rather wanes, and then your coverage is much lower. And that's why, especially for adults like us who are more than 20 years of age, if you haven't had it, you can see. I'm sure many of us are in our 30s or 40s, and you can see that you need to start vaccinating yourself, because this is going to obviously decrease as time goes along. Okay, now let's talk a little bit about diphtheria antitoxin, because A, it's very expensive, and B, it's not readily available. And this is one of the biggest problems that occurred in the Western Cape, as well as in Nigeria, is having enough access to diphtheria antitoxin. Okay, so when you look at this, okay, the WHO has come out with this really nice table about what are the doses to give patients. Okay, so 20,000 is 2 amps. Essentially, that's given to patients that have laryngitis or pharyngitis with a duration of less than 48 hours. If you have extensive pseudomembranes and a duration of less than 48 hours, you're going for 4 amps. If you've got diffuse swelling, more than 48 hours, or severe disease, you're looking at giving 8 amps to these patients. And as I said, that is not readily available. And in our cases of our outbreak, we actually had to call our hospitals around us, asking them for their stock as well. Yeah. Okay. Now, in the cases that we've seen, we try to do this PES-REDCA protocol, which essentially looks at if patients develop an allergic reaction to the antitoxin. And the problem with antitox is that it's equine derived, right? So it's like snake bite venom and stuff, where you have to have your adrenaline and your hydrocort and all of that ready. But in this PES-REDCA protocol, what they would do is they would inject a little bit of it under your skin and then wait for 15 minutes, see if the wheal increases in size. No, it doesn't. Great. It's repeated again. Doesn't increase after 15 minutes. Right. You can give your antitoxin. Now, what the WHO has done is they've removed this protocol. And the reason behind that is it then excluded patients from getting antitoxin, and therefore patients have there's a chance that they die. And I'll talk a little bit more about that in this slide over here. So what are the adverse reactions to diphtheria antitoxin? And as you can see over here, total adverse reaction sits at 24%. So 1 in 4 patients who get diphtheria antitoxin are going to have some form of side effect, okay, that's high. Right? But if you look at the proportion that get anaphylaxis, sorry, this is percentage over here. If you look over here, the percentage of anaphylaxis is only sitting at 3%. Cough, 4%. Rash, 7%. So really mild stuff. Okay, so that's why you don't need to do that anymore. And what we're saying now is that if a patient does need diphtheria antitoxin, what I would recommend is having this patient in an ICU setting or a high care setting, where you've got your crash cart trolley ready, you've got your adrenaline drawn up, you've got your hydrocort, you've got your chlorpheniramine allergics, and you're ready if something happens, okay? And then what are the indications for giving diphtheria antitoxin? So this is based on the Myanmar outbreak, which happened many years ago, 2017, okay. And what happened over there is the patients that presented with pseudomembranes, 100% were given DAT, 3% with bull's neck were given. But what I must say about this pseudomembrane is that if patients were well looking but had a pseudomembrane, they weren't necessarily given diphtheria antitoxin. They were rather just watched. And the minute that they developed severe disease and respiratory compromise, etc., then they were given DAT. And that might be related to the fact that there isn't a lot of diphtheria antitoxin available. All right, and what was really interesting is that the duration of the illness was only, of most of the patients, 66% of patients were sitting at 0 to 2 days. But this is in an outbreak setting, and this is when patients are, or healthcare workers rather, are acutely aware of diphtheria. So they react early to seeing these type of patients, whereas what we've been seeing is patients are actually presenting more than 48 hours afterwards. And then they're getting their diphtheria antitoxin a bit too late. Okay, now, as I just said, the earlier diphtheria antitoxin is given, you decrease the mortality by 76%. And for every day that you give it later, you're increasing the mortality by 4.2%. And if you give it after 5 days, the mortality is actually increased by 24%. Right. So isolation. Right. If your patient has diphtheria, how long should you isolate them for? Now, this is obviously giving you antibiotics, azithromycin, etc. 5.2 days seems to be where the disease is no longer transmissible. However, in saying that, we still follow what the NICD says, and that's for 14 days. And the WHO says within 48 hours. If you've got an outbreak situation where you've got many patients at once, it's a bit difficult to isolate many patients for the duration of 14 days. And that's why the WHO came out with this 48 hours after starting treatment. And the Americans say 6 days. I think we've taken a more conservative approach because we don't see it that often of 14 days and 2 swabs 24 hours apart after stopping treatment. All right, so I'm going to end off now. So my take-home messages are, remember what the case definition is, because we've seen many healthcare workers presenting to our occupational health clinic saying, oh, I'm a contact, but I think many of them actually weren't. And that's why it's important to remember that, especially for you guys, if you weren't wearing an N95 and gloves and manipulating the airway, well, then you're a contact. Your azithromycin, your vaccines, and your swabbing. All right, and then please don't forget the IPC principles. All right, you'll see them in, I'm sure you guys have all used them and seen them in the wards. They're the red signs, the green signs, yellow signs. Okay, they're there for a reason. All right, they're there to protect you as well as to protect the patients. And then I've already discussed a lot about the prevention of spread and ensuring that people have their azithromycin and swabbing, etc. And then don't forget, the diphtheria antitoxin is equine derived. It isn't like Panado, where there's very few side effects from it, right? But it's not something that we should hold back on our patients. And obviously, if we see a hell of a lot of patients presenting, we'll need to strategize how much diphtheria antitoxin we can use, because in actual fact, we don't have many vials at Curtis Care Hospital. So it is a bit of a problem, especially if patients present late. I don't think we would manage many patients. Okay, cool. Thanks. Are there any questions?
Thank you, Terry. It's a very nice presentation.
Pleasure.
Just one question from our side. One of the questions comes up is how we transfer potential cases. Because obviously there's a lot of symptomatic overlap with other, infections we see, and even, non-benign pathology. So if we have, and a lot of these cases are coming from Victoria, Mitchell's Plain, etc., how do you suggest we transfer them? Would it be directly into an isolate? Obviously tell people that this may be diphtheria and take the next precaution to their side, and then transfer directly into one of our isolation rooms?
Yeah.
Because I suppose casualty wouldn't be a great idea.
Yeah. So what we've been saying for the previous outbreaks that we've had is, if the patient can remain at Vic or Mitchell's Plain or whatever, rather let them be managed over there, because of the issues of the transfer across. And from experience, what we've seen is there's always a breakdown in communication. So even if the Victoria doctor calls you guys and said, hey, listen, I've got a potential diphtheria, I need to transfer across. And then they let C15 know. But because we're such a big hospital, inevitably what happens is someone in C15 actually doesn't know this patient has come across. And then what's happened in previous episodes is that we then, as IPC, had to go and do a contact tracing. Even though we knew the patient was coming across, people knew, but not everyone knew. So, as I said, if a patient's well, that doesn't need tertiary level care or doesn't need specifically ENT input, because I know they've got an ENT at Vic, then let them rather stay there.
Yeah, I'm a sessional ENT. I'm only there once a week.
Oh, is it? But isn't
Sean Longers, but He's a
medical officer.
He's a general surgeon, medical officer.
Okay. Yeah. So I mean,
sorry, the other problem with that is often we're getting referred when these are really quite complex. Patients with airway obstruction. You're not really safe to sit there.
Yeah, 100%. So in that case, if it's possible, I would say transfer the patient from Vic directly into one of your cubicles over here. If the patient needs intubation, ICU care, then that patient must go straight into P26. And importantly, what we sometimes miss is what about the ambulance staff? We need to make sure and say, hey, listen, when you book this patient, please make sure you tell them that this is a diphtheria. And we've actually even had problems with our forensic pathologists where they call us and say, but no one let us know this was a potential diphtheria. So I've been in communication with them trying to make a standard operating procedure, SOP, to say, what do you do when you're worried about a patient that has potential diphtheria? And now in the cases, sometimes we don't know, and then the patient demises, and then a few days later, someone says to Micro, hey, Micro calls us or you guys, hey, this was a diphtheria. And then we forget about the people outside of Criticia that also get exposed to it. So it's complex. If we're a small hospital with small amounts of doctors, I think it would be a lot easier to transfer patients.
And then the one problem I think the registrars have been having is getting the diphtheria testing done.
Yeah.
The last case we waited 48, 72 hours after a repeat swab. How do you kind of circumvent that, dropping it off at the lab, emphasizing the importance? Any other measures?
So there's always someone on call for micro and infectious diseases, but the person to call for the swabs would be the microbiologist and say, hey man, I've got a very important swab. I need it to be done as soon as possible. I'm going to bring it down, and then I would hand it to the guys in the lab and say, here's the diphtheria sample. The problem is with the sample is the micros need to incubate it and they need to plate it, and that process takes time. And also, it also still needs to go to the NICD because we don't have the facility to see if it's a toxigenic strain. Because the toxigenic one is the one I'm worried about. That's why we're getting diphtheria antitoxin. Right. If it's a non-toxigenic, they're not likely to have membranes anyway, because it's a toxin that does that. So I think it's making sure that there's good communication and informing infectious diseases, micro, etc., and IPC, and then we take it from there. And that's why like if you're worried about it being a diphtheria, you're not going to get that result for 48, 72 hours later. That doesn't mean you mustn't give your diphtheria antitoxin. If this clinically looks like it, you must do it. And that's what we've done in a few cases that they called me about outside of Criticia. Didn't have a result, patient sick, right, give the antitoxin, let's go.
And then what I'd also like to know from you as an infectious diseases specialist is a lot of overlap is with severe pseudomembranous tonsillitis, quinsy. So what should be our first line antimicrobial in these settings where you want to cover for both potential scenarios?
You guys normally give comoxiclav, right? I have to think about it a bit more. Sure. I'm wondering if Azithra will cover all the other gram negatives that you guys would be worried about.
But if it's EBV, it's viral, so you don't have to answer for that anyway. I suppose the Azithra max should cover.
It should.
Yeah, it should. Just wanted to ask, have you had any patients who actually survived, or the ones that have been transferred, have any of them survived?
Sure.
I don't think they have. I've always just heard they've died. The ones at Red Cross and the ones here, no one's actually survived the pseudomembranous.
No, exactly. I think it's related to the fact that we're picking them up late.
I think we're missing, to be honest. I think they're getting misdiagnosed and covered.
Well, no, because they probably don't have the one of the toxigenic one.
So I've seen toxigenic, not here in Durban.
Is it?
And then got all meds and was fine.
And it was fine.
Then they had a big problem with contact tracing.
Oh, really?
Yeah.
Yeah.
Diseases weren't happy. That's
I've just never seen the ones that have come in with airway issues survive.
Yeah.
You know, the bull neck, pseudomembrane, stridal, the one that we get asked for trachea, they've never made it.
Yeah. I think it's a late presentation. That swelling is just so severe that they're getting it.
People that have died of cardiotoxicity.
Yeah. Yeah. We unfortunately have had a case like that as well. One that I saw as well, which you guys were involved with, I think.
Yeah. Is there a delay in the transfer, do you think? From what I'm saying is from the community level to the hospital.
I'm not sure. I think many of the patients that we've been seeing are just presenting late to the peripheral hospitals. Because like you see in an outbreak situation, like I mentioned in Nigeria, everyone knows this diphtheria. The patients know, the community, the lay person knows that there's diphtheria running around. So they are acutely aware, oh, my neck is painful, got a sore throat, go see the doctor. Whereas, we're not seeing that many cases. It's more sporadic. People are not acutely aware of it. And the cases that we've dealt with, none of them have been related. The ones that we've seen. Yes, the ones out in the community where there's contact tracing, they've picked up others. A mother of a child, a friend of the child. They've seen those cases, right? But how many are related? Those sporadic cases, it hasn't been a lot. Yeah.
Can you consider diphtheria and steroids? Because that's also, we usually give upfront quite high doses for severe tonsillitis.
Yeah.
I
I haven't read anything about the issue with giving steroids to the diphtheria. I guess the issue is killing the bacterium versus decreasing the amount of edema that's around there. And I think if there's so much edema, that's going to kill the patient before the actual diphtheria itself does. So I wouldn't hold back. If you guys feel that this patient needs hydrocortisone or whatever, go for it.
Yeah.
And then give the antibiotic as soon as possible. And if they're so sick, don't go oral azithromycin. Whack them IV.
I mean, I think with the number of patients that we see, that because as Matt said, there's quite a lot of overlap, and sometimes you just get this patient got a sore throat and a swollen neck, and that could be lymphoma. It could be so many things. I would just ask the registrars to wear N95 with all those cases because you don't know.
Yeah.
I mean, it's pretty negligent to not have eye protection if you're going to scope a patient like that. And wear an N95 and put for your own protection.
100%. I completely agree.
Yeah.
I mean, the case that we dealt with was it last year? They saw the patient in one of the peripheral hospitals, and they saw this massive neck, and everyone was like lymphoma. And then they discussed it with you guys. Patient came across, and then the penny dropped, and people when they looked, they're like, oh gosh, there's actually pseudomembranes, and that was a disaster because everyone in that peripheral hospital needed to get their azithromycin and whatnot.
Yeah.
Anyway, it is. Unfortunately, we're going to be caught up. We're going to be caught. I'm telling you now, even though we talk about it, we're still going to be caught up because it's not happening as often as it's not happening that it's always reminding us. But this is life, right? That's why I think, as Tashnima is saying, if you're worried about this patient, just wear your N95 and your eye protection. Are there any questions from online? It doesn't look like it. Okay. How long is the chemoprophylaxis? Okay, great question. Thank you. So the chemoprophylaxis depends on. Let me get the slide. The chemoprophylaxis depends on whether you're toxin positive or toxin negative. If you're